The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Kashlak Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Well, Paul, we're back, and this was a hospital medicine show tonight, huh?
Yep, no one would argue. Matt, how are you?
We're talking about acute pancreatitis, and Paul, I imagine as a primary care doctor, you don't see much of that, but fortunately, we have two great hospitalists with us from our hospital medicine team who we'll introduce in a second. But, Paul, before you do that, can you tell people what is it that we do on the Curbsiders?
Sure. Happy to, as always. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And as you mentioned, we have our Kashlak hospitalist experts with us, Doctors Meredith, Trubitt, and Monee, Amin, both of whom will tell us a little bit more about our guest and our topic. Why don't we start with Meredith? Meredith, lovely to see you. Why don't you tell us a little bit about what we talked about tonight?
Sure. So we had a great guest with Dr. Kaveh Sharzehi, and we talked a little bit about acute pancreatitis, walked through a first case with a little bit more mild case to go through kind of the diagnostic workup, and then a second case to go through a little bit more of the complications of acute pancreatitis.
And a little bit more about Dr. Sharzehi. Dr. Kaveh Sharzehi, he earned his medical degree from Tehran University in Tehran, Iran. He completed residency in internal medicine at Henry Ford in Detroit, as well as fellowship in hepatology at the University of Miami in Florida, gastroenterology at Penn State University, and advanced endoscopy at Fox Chase Cancer Center. He served as gastroenterology faculty at Temple University in Philadelphia before joining OHSU faculty in Portland, Oregon. His clinical interest is benign pancreatic disease, and he currently serves as the medical director of endoscopy and the co-director of total pancreatectomy with islet auto transplant program at OHSU.
No puns?
Ain't nothing acute about it? What?
A reminder that this and most episodes are available for free CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. Kaveh, take two. So the audience, for the audience, this is take two here. We had cat-related technical difficulties, which I'm sure surprises no one in our audience, Paul. It really can't.
It's usually not Kaveh, me, though, but yes.
It's usually not. That's true. Kaveh, can you give the audience, tell them a little bit about yourself. They've heard your bio, but tell them a little bit about yourself, how you describe yourself, and hobby or interests outside of medicine.
Sure. I'm 44 years old. I live in Portland, Oregon. I'm also a husband and a father of two sons. When I'm not too busy with work, I build and collect Legos. You can see a couple in the background right there. And I'm also a very avid reader of automobile magazines. If you ask me right now about Charger Hellcat model 2019, I might be able to recall some of the specs of that. And I also love the famous sitcom Friends. Me and my wife, we're sort of addicted to it to some extent. So we watch that over and over.
There's got to be a Friends rewatch podcast. I bet you that exists. I know there's one for The Office.
There has to be many of them.
Yeah.
There's many offshoots. Leather Pants will go down as a great episode.
Pivot. Pivot's the best episode.
All right, this is going to devolve. Paul, you better ask your question.
Yeah, usually I ask about books, but I don't have the bandwidth for books right now. I'm now stacked back up, so I will ask about the Legos. In the background, right where I'm pointing, is the Ecto-1 Ghostbusters car. That was my favorite thing that I put together from Legos. So I'm going to ask you what your favorite Lego set was, which is maybe the nerdiest question I think I've ever asked on this show, which is saying a lot.
So the nerdiest Lego I have, I guess, it's a 2003 or 4 pirate ship. I think it's hard to find, so it's almost a collector's item.
About how many pieces? And then I'm done nerding out.
I think it's 1800. I'm just going off.
That is exciting.
Well, Paul, maybe you could send Paul a picture of it. I think we should give Meredith or Monee a chance to ask anything else before we get on to the main topic here.
I have no frame of reference for what just happened.
My recording studio, our basement has stairs that come down the middle, and my recording studio is to the left. To the right is 20,000 Legos. It's ridiculous. It's
magnificent.
10 years worth of Legos. So I do have a frame of reference. 1,800 is a very large Lego set.
Okay, yeah, like outside of stepping on one and hurting my foot, I got nothing.
This is why the two of us are friends. Similar things happen to me.
All right, Kaveh. Why don't you tell us what kind of is the best advice you've gotten throughout your career?
There are so many good advices I got, but a very practical, simple advice I actually recently received, not more than a couple years ago, is to have a monthly planner and set 3 goals for a day, 3 for a week, 3 for a month, and then keep updating it on a weekly basis. And it has helped me tremendously because we always want to do more and more and say, I want to do 5 tasks a day, and it's just not practical. And keeping it simple, I think, has really helped me a lot in managing my work and my work-life balance.
I think it's pretty easy to overestimate how much you can get done in a day, and you're going to feel bad if you try to do 5 things and you don't get to them. I think it's nice that you're setting that goal. That sounds great.
I feel like that extends to lots of things. For instance, working out. It's not always possible to do even a half hour. 5 minutes might be the best that I can do. So keeping it simple and keeping realistic expectations, I think, is always a good plan.
Yeah. It's like making your bed is a small win for the day is one thing that I've heard people say. This podcast is sponsored by BetterHelp. Audience, we've had BetterHelp as a sponsor for over a year now, and as you know, I was using BetterHelp long before they were our sponsor on the show because I think taking care of your mental health is really important and should be one of the most important things that we all do, but let's face it, a lot of us don't do it because there's a lot of barriers. Maybe you worry about stigma. Maybe you just feel like you don't have time to go to a therapist's office, and maybe it's hard for you to find a therapist and switch to one you like. Well, BetterHelp, they can solve all that because they make it easy to sign up. You can get started with a therapist in under 48 hours, and it's really easy to switch therapists if you don't like the person you're paired with initially. Stress shows up in all kinds of ways for us, and in a world that's telling us all to do more, sleep less, and just grind all the time, I wanted to remind you to take care of yourself, do less, and maybe try some therapy. BetterHelp is customized online therapy that offers video, phone, and even live chat sessions with your therapist, so you don't have to see anyone on camera if you don't want to. It's much more affordable than in-person therapy, so give it a try and see if online therapy can lower your stress. Curbsiders listeners get 10% off their first month at betterhelp.com/curb. That's BetterHelp, BetterHelp.com/curb. So since we have limited time, Meredith, would you take us to our first case from Kashlak?
Sure. So our first case is Mr. Johnson. He's a 40-year-old man with no known past medical history, but when you're asking him, he tells you he hasn't seen a doctor since he was at the pediatrician. But he presents to the hospital with a raw, dull, aching, burning epigastric pain that radiates to his back. He reports that the pain started acutely last night after his nightcap. And when you start asking him a little bit more information about his nightcap, he elaborates and tells you that he drinks a 5th of vodka nightly, actually. His vitals are significant for a heart rate of 111, but everything else is normal. And then his physical exam is unremarkable except for tenderness of palpation in the epigastric region. His labs are notable for a slightly elevated white count of 14.3 and an elevated lipase of 491. He has an elevated AST at 91 and a slightly elevated ALT at 45, but alk phos is normal at 54. And in the ER, they had ordered a CT abdomen and pelvis, which showed peripancreatic stranding and no fluid collection and some hepatic steatosis. So in thinking about this case, Kaveh, is there other information that you would like to gather from the history and physical that may help you in thinking about his diagnosis?
So that's a great question, Meredith. And I think because even though we want to try to be very comprehensive in our assessment, this case, at least a description of it, it's fairly straightforward in the sense that you're defining a very classic presentation of acute pancreatitis. You're describing, acute symptoms, the classic type of pain, and also demonstrating a lipase elevation. I'm assuming this is probably more than 3 times, but I don't have a reference here. And as a bonus, we also have a CT scan, which is showing already a peripancreatic stranding. So in regards to diagnosis, I think there may not be more information needed at this juncture. 2 things I would like to know in this patient, which are covariables for the severity of the disease and helps me prognosticate him, is one is what is his BMI currently, because we know severity of acute pancreatitis, it is much more pronounced in patients with heavy BMI or metabolic syndrome, and smoking status. Again, another predictor that the disease could be more severe or if there could be more associated chronic pancreatitis in the setting of tobacco use. So that would be sort of 2 other pieces of information which I think would be helpful to know at the beginning when assessing the patient. Otherwise, may not need much more information at this very juncture.
So that's interesting that you bring up those 2 as kind of risk factors for maybe worse prognosis. And so could you also then talk a little bit about some of the other scoring systems that we may or may not use like during acute pancreatitis and kind of their value for them? Or are these 2 other things maybe more valuable?
So this might be a good segue into the scoring system question. I think over the course of years, multiple and different scoring systems have developed to assess or help us assess severity of acute pancreatitis. Ranson score, Apache score, which essentially they all have one issue or issues with low specificity. I mean, basically, they have a fairly high rate of false positives, all of these scoring systems. And when you couple this with a fairly low prevalence of severe acute pancreatitis, or severe to moderate to severe acute pancreatitis, then you are resulting in a fairly low positive predictive value. So despite of these being discussed for over years and decades, it's not been used that often, and it's sort of fallen out of favor in many instances. Perhaps one of the most reliable and the best metric to assess acute pancreatitis, and it's been something which has been more or less referenced in more recent guidelines, is the Atlanta classification, or more accurately, the revised Atlanta classification, which simplifies acute pancreatitis into under 2 buckets of type and severity. So you have the 2 types. One is interstitial edematous pancreatitis pathway or type, and then you have the acute necrotizing type. And in regards to severity, you have mild, severe, and moderate. And it's very easy and practical system to use. By definition, mild is when there's no organ failure and there's no local complication. For example, the case you described does fall into this category because, at least based on what we have so far, this is we're not seeing evidence of organ failure, and imaging was unremarkable in that sense of having any local complication at this juncture. And then we have severe, which is persistent organ failure, either respiratory, cardiac, or renal, on a modified Marshall scoring system. And then moderate is sort of falls in between. It's either transient organ failure, which resolved in 48 hours, or local complications without organ failure. So it's very easy to use, it's very practical, and I think it's been a very valuable tool in trying to assess and manage acute pancreatitis.
Yeah, I love that breakdown, because classically you'd always hear people talking about like the Apache and the Ranson score, and I mean, I think it's just practical to size the patient up and think about SIRS criteria and then just classifying it the way that you were telling us. One thing that struck me about that is oftentimes we have the CT scan because the ER, I can't judge them. I don't work down there. They get, a lot of these patients just end up coming in with a CT scan, but it's not required to make the diagnosis, right? You can just make it by the 3 times upper limit normal, lipase, and then just the classic symptoms. So maybe we wouldn't know if they have the interstitial edematous or the necrotizing, but we could still grade it as mild, moderate, severe based on just clinically what's happening. I'm not sure if that's how you think about it as well. And can you comment on what you look at, like what worries you about this patient or doesn't worry you about this patient, like when you're sizing someone up?
So I think that you bring up 2 good points. One is imaging. We can talk about it right now or a little bit later if you want to. And one is how we sort of try to assess the severity in a particular patient.
Yeah. Let's table the imaging and let's do this. Let's go with the severity.
Yeah. So for severity, I mean, essentially in this particular patient that we described, we are not seeing any changes in oxygenation. We're not seeing hemodynamic instability beyond just a mild tachycardia, and there is a Marshall scoring system that we can look at. And if someone scores essentially more than 2 in each category, that defines organ failure. If not, then there is no organ failure, or that doesn't categorize as organ failure. So in this particular patient, looking at him, to the initial assessment, it sounds to be mild acute pancreatitis. We may not know if it's interstitial edematous at this juncture, necrotizing. It may not even be important at this juncture to know this information. As I mentioned earlier, what I want to know about, does this patient have any other risk factors that impacts his management, including does he have uncontrolled blood sugar, does he have ketoacidosis, does he have diabetes on top of this, is he a smoker, which could signify more severe disease? And if he's in the obese or morbid obese / metabolic syndrome category, that will make us worried. But short of that, I think this is fairly uncomplicated mild pancreatitis based on the description.
Yeah. So it sounds like you're not as worried about this guy because he doesn't have organ failure. He's got a little bit of tachycardia. We'll see if we can fix that. And then we haven't given you that he's a smoker, that he has hyperglycemia that's severe, or that he's got a really high BMI. So, okay, thank you. That's helpful.
So finding out whether someone has tobacco use or obesity, or even like the prognostic scores like the Apache or the Ranson, I think something I always struggle with at initially, how does that change your management? We'll get into management stuff, but I mean, short of saying, oh, I should be more nervous about this person, like how, does it change anything in terms of your initial workup at all?
So I think if the patient is demonstrating organ failure, it does change how you want to treat the patient, at least, or house them in the right place. If someone is already showing evidence of, respiratory failure, if they're already tachypnic, or they're having low saturation, or if you're getting a blood gas on them and their FiO2 is low, so you're getting more worried about these patients that they already have multi-organ failure at the very get-go. And those are patients you may want to have a low threshold for an intensive care unit evaluation or care. And then I think you manage them as based on their organ failure. If someone is getting into persistent hypotension, tachycardia, remain persistent hypotensive, they might need ICU level of care for more aggressive fluid management. They may need monitoring of their CVP and renal output if they're evolving into that multi-organ failure sort of pathway.
Yeah, before we get too far into treatment, there's just one piece that I think always sort of looms over everyone, which is this, like, you kind of brushed on the lipase value being, I don't know if it's 3 times the upper limit of normal, but I think one of the things that I frequently run into when I'm working with learners is this tendency to want to trend the lipase, and sort of what utility, if any, is there in trending a lipase?
Yeah, that's a great question, Monee. I often have arguments do rounds about this because trainees sometimes want to trend and say, the patient is better because the lipase is better today. And that has zero value almost in my mind in management of these patients. And that it's not necessarily my personal idea. We know based on good amount of literature that the lipase value does not indicate severity. It does not correspond with severity of disease, and improvement of that does not also mean that the patient is improving. I mean, your clinical assessment of the patient, your assessment of how the organs are perfusing or not, that's way more valuable than the value of lipase. So I discourage people from trending it or following that value.
All right. I will reinforce that with learners extensively.
It's very, I know it's very tempting to trend anything. It makes us feel good to see it getting better. That's just the nature of being an internist. Before we leave, since we're on diagnostics, I think now is a good time to talk about the imaging. And the guidelines would say first 72. I was surprised because I see so many patients like this one coming in with a CT, but the guidelines would say start with an abdominal ultrasound. You're looking for kidney stones or sludge, or maybe you can tell us what else you look for in that. But And I even read that sometimes in the first 72 to 96 hours, if it takes that long for necrosis to develop, so it might not be worth getting it in the first 72 hours anyway. Can you speak to how you think about it?
This is a great question, Matt, and I think you're touching on a very important part of information, that CT scan in the first 2 days or 48 hours has a very limited value in helping you manage the patient. It might serve if the other two aspects of a diagnosis, the symptomatology or the lipase, is equivocal and you need that third arm or third item to help make the diagnosis. But if you already have a clinical diagnosis based on the symptoms and lipase or amylase elevation, there is no need for a CT scan or cross-sectional imaging in general in patients because, number one, it won't impact how you're going to manage these patients. It does not show evolution into necrosis within the first earlier times, and it does not add to the only imaging which it comes frequently in guidelines, in AGA, ACG guidelines about management of acute pancreatitis, would be done ultrasound with the purpose of evaluating for biliary stone and biliary sludge as a component or as a cause of acute pancreatitis. For example, in this patient in particular, you do have AST, ALT elevation, which may query if there is possibility of a sludge or stone. So I think it's a reasonable tool to do it early on. It's non-invasive, does not involve an IV contrast to affect the kidneys at this early stage. So I think it's a reasonable test to do. Granted, in this patient, probably the AST, ALT elevation is from alcohol use given the ratio of it, but I think it will be a useful tool at the early sets, especially if the history of alcohol is not as clear as depicted here.
On that note, I know this case gives you a pretty clear alcohol-induced pancreatitis. When you have patients that come in similar to this, where they give you a pretty clear alcohol history, is there much role to kind of be looking for alternative etiologies still to make sure there's not two things going on, or do you kind of just stick with kind of what you already know?
So that's a great question. I think there are only really one or two other etiologies that it may impact your management early on. If this is alcohol-induced pancreatitis, there's not much to do about it in regards to etiology. Gallstone, you may need to know that, as you point out. Beyond that, the only two other things that could impact early management will be knowing the triglyceride and the calcium in the case that these are induced by hypercalcemia or hypertriglyceridemia. The triglyceride, I take it with a little bit of caution because sometimes in the setting of acute pancreatitis, it can elevate after a few days. So if it's done in a week later and it's elevated, it might be secondary, not primary cause of pancreatitis. So that might be the two additional tests I order in regards to etiology, because you may want to treat them aggressively if they turn to be the culprit for pancreatitis in the first few days. But beyond that, I won't recommend doing more investigative, looking into things like autoimmune pancreatitis. This is not the right time to investigate for those etiologies.
Yeah, that's helpful. I think we kind of at the end we'll kind of come back to some transitions of care stuff that I think will be good discussion points. I think we've hit the diagnostic stuff enough. So I think it's probably reasonable to sort of delve into some of the staples to management. So I think the age-old question starts with fluids. We know that's kind of the initial management for most patients that come in with pancreatitis. So I guess it's important to sort of think about what fluids to give, what grade, what amount, that sort of thing, before we kind of go from there.
I think that the preferred fluid, there is not really much of a preferred fluid, but many references or many guides recommend lactate ringer over NS or normal saline. It's not something if it's not available, it's sort of a tiebreaker in my mind. It's going to be an issue for the patient if it's not available, but I think the preference is lactate ringer. And the only reason not to use LR if someone has history of a hypercalcemia-induced pancreatitis. But short of that, it could be used in pretty much all causes of acute pancreatitis. The fluid rate should be something around 5 to 10 ml per kg per hour. I think one of the key things I try to hammer a lot during rounds is the importance of fluid resuscitation within the first 24 to 48 hours. And if that time frame lapses, then after that, it does not really help much. Giving sort of liters of fluid during the first 24 hours, it could actually prevent patients evolving from interstitial pancreatitis into necrotizing pancreatitis. The reason for that is as the pancreatitis sort of evolves and we have increased build of interpancreatic pressure, that does contribute to further and further ischemia within the pancreas. So you do want to maintain adequate arterial supply to the pancreas so it does not evolve into necrotizing pancreatitis. So more important than the type of fluid, I think it's giving the amount of fluid very early on. Because once the pancreas starts necrosing, then there is no you can't reverse that. There's no turning back from that point on. Hitting it with fluid very early on and something in the ballpark of 2 to 500 mLs even per hour in the first few hours, that can prevent your patient from developing necrotizing pancreatitis. Not that all will be prevented or all causing necrotizing pancreatitis is inadequate resuscitation, but that's something that is very critical.
The LR versus saline thing is, I think, still being fought out. Paul, we're going to be talking about that again this week for a different topic, but there's a Lancet seminar paper from 2020 that came out on acute pancreatitis that in that one they said that it looked like when they gave LR versus saline, it had decreased development of SIRS and reduced CRP concentrations, but not necessarily like hard clinical endpoints. But like you said, the guidelines some of the guidelines recommend LR, so I think that's still being fought out, but it seems not as crucial outside of the situations you said. I wanted to ask about pain, though. I mean, some people, this Lancet article says use the WHO's pain treatment ladder, but what's your approach? Do you have any favorite medications? Not brand names, of course, but just any favorite medications or regimens, cocktails that you give patients?
So I don't have much of a favorite pain regimen, but many references do recommend either hydromorphone or fentanyl, even though fentanyl sounds short-acting. But I think obtaining or achieving good pain control is very important as well in the early phases, not only for the patient's comfort, but actually if the pain remains persistent, that can actually, it's by itself, increase catecholamines and by itself can cause more vasoconstriction and ischemia within the pancreas. So some believe, some references do recommend trying to be fairly aggressive with pain management because decreasing the pain will decrease the catecholamine release and may, in theory, improve pancreatic perfusion and prevent ischemia again. So, I mean, I think there is a lot of different ways and different medications to control pain, but I think, at least in our institution, our preference is hydromorphone and fentanyl. But that's sort of an institutional preference.
This episode is sponsored by MedMastery. Audience, you've heard us mention MedMastery on the show before. MedMastery is a fun and effective way to learn really important clinical skills. It's an award-winning learning platform that's endorsed by the British Medical Association. What MedMastery is, they have these short videos with pre-tests and post-tests. They break concepts down into these easily digestible parts. So let's say, like me, you wanted to brush up on your EKG skills and build towards higher level skills. Well, MedMastery has a great video course on that. Or maybe you want point-of-care ultrasound, how to interpret a chest x-ray, brush up on some echocardiography. These are just some of the great courses that MedMastery offers. And like I said, it's super practical and the videos are fun and easy to go through. And they feature amazing educators like your favorite, Dr. Joel Toff, Kidney Boy himself. These courses are great for people working in internal medicine, family medicine, emergency medicine. The subscription is affordable, and all the courses are peer-reviewed and CME accredited, and residency programs can even ask about group subscriptions. Listeners of our show can claim a 15% lifetime discount on any of their subscriptions. Just go to www.medmastery.com/curbsiders to claim your discount. Again, that's www.medmastery.com/curbsiders.
So, Kaveh, back when I started residency, back when we were doing therapeutic leashes and chicken sacrifices and stuff, there's this idea of bowel rest. So patients who are having symptoms of pancreatitis, you just didn't feed them because you might get the pancreas all kinds of excited, and then you would make things worse. And I think things have sort of evolved, but I would like to hear your thoughts on when we can feed these patients and sort of what that looks like depending on how severe the illness is.
So I think this has evolved, and I think will continue to change and evolve over time. I think for cases of mild to moderate acute pancreatitis, it's very reasonable to start early nutrition and early PO nutrition if the patient tolerates it. So as long as the patient does not have nausea, is not at risk of vomiting or throwing up, and they're not exacerbating their pain too much by eating, I think that many references are recommending early nutrition, even as early as 24 hours. And the preferred diet would be just a low-fat diet for these patients.
Before you move on, can I ask
Sure.
about consistency? Because I know this sounds bananas, and I'm sorry for those of you who are already experts in this, but I feel like I sometimes see misguided like puree diets or mechanical soft diets.
No, it does not.
What are we doing here? Is that...
Yeah, the consistency is not really of a significance as long as it remains low-fat. I think there is.
Great, thank you.
It could be pureed, it could be solid. It doesn't really matter in that sense.
I usually just tell the patient not to have like a bacon cheeseburger as their first meal.
That would be great, yes. And one thing I would advise is do not trend the lipase before feeding the patient, because that's something I've seen that practice as well. Because we can start nutrition now because the lipase is trending down, and that shouldn't be the case.
And we should say it's an unusual thing for someone to need TPN for pancreatitis. Certainly for us as hospitalists that are seeing patients, because we tend to see the mild or moderate cases, not really the severe cases, unless they're coming out of the ICU. But can you talk to when do you even think about TPN? So
we really, really do not like TPN. That's how I say it.
Okay.
And even in moderate to severe case of pancreatitis, even a patient in the intensive care unit, we try to find after you start enteral nutrition for them, even if they're not able to tolerate it by mouth. And that could be placing a drop-off tube into the duodenum or jejunum to feed them. So overall, enteral nutrition is better than parenteral, better than TPN. What it does, it maintains intestinal barriers and does reduce bacterial translocation, and may prevent you developing from a sterile necrotizing pancreatitis, for example, to an infected necrotizing pancreatitis, because you are keeping your mucosa, your GI mucosa, intact by feeding them. Even if in some instances where patients have severe pancreatitis, are intensive care unit, and they're simply just not tolerating even jejunal, and they need to be on TPN, we still recommend trickle feed as 5 mL per hour, just for that, just to minimize the risk of infection by maintaining their mucosal barrier by giving their nutrition. In our institution, we do have a very low threshold to place post-pyloric enteral access and start nutrition within 48 hours, even for severe cases.
Okay, Meredith, before we leave this case, can you tell us the conclusion, and can you give us just a quick recap of your, the big things that we need to remember from this first case?
Yeah, so for Mr. Johnson, who's our 40-year-old with alcohol-induced pancreatitis, it sounds like for thinking about other etiologies, we would want to consider potentially gallstone pancreatitis, maybe checking triglycerides and his calcium levels. It sounds like the other kind of big points we hit on were other variables that were important for prognosis, such as his BMI and smoking status. And then talked a little bit about kind of the role for best timing for CT scans. So while we often get them directly from the emergency room, that maybe the best timing for them is closer to the 72-hour time point to kind of evaluate for necrosis.
So, and how did it end for Mr. Johnson? Did we make him better with our aggressive fluids and pain control and early feeding?
We sure did.
Yeah, how's his lipase?
We did get another one. No, I'm just kidding.
We did not get another one. He is at home. He is at home, and I heard he is back to his normal diet, so he's doing quite well.
And Paul, we offered him naltrexone at discharge, and we tried to connect him to resources to quit, to help him with his alcohol use disorder. So now, I think, Monee, you're going to tell us about the next case here, right?
All right. So next case, Miss Weber, she's 48. She has a history of hypertension, diabetes, and dyslipidemia. She presented to the hospital with a one-day history of nausea, vomiting, mid-epigastric abdominal pain, and said she denies any recent changes to her medications. She denies any tobacco, alcohol, or street drug use. She reports that her birthday was yesterday, and her family took her out for her favorite, which is fried chicken, mac and cheese, mashed potatoes and gravy, and peach cobbler for dessert. On arrival to the ER, she was afebrile with a heart rate of 117. Other vitals were relatively normal, mildly hypotensive with a blood pressure of 103/76. Exam was unremarkable except for tenderness to palpation in the epigastrium, and her labs were notable for an elevated white blood cell count of 16, mildly decreased hemoglobin of 11.9, and then most notably a creatinine of 1.5. With an unclear baseline, alk phos of 350, mildly elevated AST and ALT of 78 and 87 respectively, and a T-Billy of 5.1 and lipase of 525. She had an ultrasound of the abdomen that revealed moderate biliary dilatation without signs of obstructing stone. So I think we already kind of talked about this in the last case, but just kind of hit it home further. What utility would there be for cross-sectional imaging now, given that we do see some biliary dilatation versus maybe potentially down the road, and sort of what imaging would you consider at what time?
So this case is also sort of trying to classic or clearly describing a case of gallstone pancreatitis, where you have the right demographic, right type of patient, presenting with pancreatitis, and you're demonstrating the cholestatic pattern, LFT abnormalities, and ductal dilation. So the question is if there is any utility for cross-sectional imaging at this juncture, and I think the answer remains no. You already have demonstrated that based on the ultrasound. I think if there was no evidence of ductal dilation or no evidence of stone disease in the gallbladder, that might be something to consider, because there was uncertainty about the diagnosis, whether this is truly gallstone pancreatitis or not. But I think between the evidence you've demonstrated here, I think what we have obtained at this juncture is adequate for making a diagnosis.
And say that she didn't have that, what imaging would you consider? Because I always feel like I get stuck with, like, do I get the MRC before I call GI? Do I call GI and then get, I feel like that's sort of the conversation I have in my head every single time. And Meredith hears me have this conversation in the workroom very frequently.
So that's an excellent question. I think getting an MRCP or MRI with MRCP, it's not going to change much unless the patient is demonstrating signs of cholangitis, which will twist our arm to do an urgent ERCP. If the patient even has a stone there is no need for an urgent ERCP within 24 to 48 hours. So you do have time. There is no need sort of to rush for an MRCP. So you have the option of watching her clinical status in the next 24 to 48 hours, see how her LFTs progress. If they are downtrending, if they improve by day 2 or day 3 after admission or 48 hours, then we can presume the stone has passed or it's not obstructing. But on the other hand, if her LFTs are deteriorating or clinically not getting worse, then you may want to obtain an MRI, MRCP, or consult gastroenterology to help making that distinction if she does have an obstructing stone or not. If she has clinical evidence of cholangitis, which it's not being depicted in this case, if you have right upper quadrant tenderness with fever and jaundice, then that will change. You probably will need a gastroenterology consult early on, and maybe they will recommend or getting an MRCP early on to assess for stone disease, obstructing stone disease or cholangitis.
And this patient sounds sicker than the last one, right? Because they have maybe a little bit of organ dysfunction with the creatinine, and they're borderline hypotensive. Just more worried about a patient like this. And maybe this isn't the exact right time, but since you're talking about the interventions, I think the timing of the cholecystectomy for a patient, if we do confirm that there's stone disease here, the timing of cholecystectomy, is that very controversial? When to do it for patients? Does it depend on severity?
No. I mean, assuming this patient improves in the next few days and she's not deteriorating or evolving into something like severe pancreatitis or developing a complication like pseudocyst or wall-off necrosis, then she should undergo a cholecystectomy within the same admission. So we have fairly strong recommendations by different societies that index cholecystectomy is indicated, and it should be considered because it will prevent a patient being back in hospital or prevent recurrent gallstone pancreatitis. And if that's delayed, you might face a risk of recurrent gallstone pancreatitis as high as 25-30% within 6 weeks, or 6 to 18 weeks, depending on what reference you look at. So for mild cases of pancreatitis, we do often recommend cholecystectomy within the same index hospitalization before discharge.
Yeah, for more severe cases, are those the patients they quote like cool off and then bring them back in 6 weeks and do it?
So if patient has a severe disease, which we discussed already with organ failure, or they have developed complications like necrosis, then we do want to wait 6 weeks after their hospitalization and consider cholecystectomy more of an elective route before and maybe in a second visit.
Yeah, and you kind of alluded to this, Matt, but this patient is a little bit sicker. And so I guess the other question I sometimes have to either answer for myself or for learners is she does have an elevated white cell count. She does meet some SIRS criteria. I guess the question is is there a role for antibiotics in her? Or if not now, when would be an appropriate time potentially for that?
So that's an excellent question. And I do actually, sometimes when I give this talk to our residents, I keep changing the story or the case a little bit to see if I can provoke them to start antibiotics or not. And the answer is the only role of antibiotics in acute pancreatitis if you're treating a complication or cholangitis. By complication, I mean, let's say the patient has aspirated throughout this hospitalization, has now pneumonitis or pneumonia, and you're thinking about that could be the source of fever or infection, or patient has UTI or has developed urinary tract infection from prolonged catheterization. Those are the cases that should be treated with antibiotics, but within the first 10 days, just purely a SIRS should not really push us to start antibiotics. But the only exception will be if patient has cholangitis, and that will be early antibiotic therapy. But we keep doing a scenario, day 5, patient is febrile, white count is 20,000. Is it the right time to start the antibiotics? The answer remains no, because when we hit the 10-day mark, then we start getting worried about development of local complications like an infected walled-off necrosis or infected necrosis. It might not be walled off by that juncture yet, and then we do start repeating imaging, looking for these complications, and then act on that.
How high does the fever tend to get in these patients before you're worried it might be something else? Are these 101, 102, or if you see a fever 104, does that happen? I don't know that I've seen it with pancreatitis.
I mean, I think these are usually fevers within the 101, 102 range. It doesn't usually mount to the point of 104, 105. I haven't seen or experienced cases with that like that. But I think what I'm trying to emphasize is having fever within the first 7 to 10 days, even with leukocytosis and other positive SIRS markers, should not indicate or should not be a reason to initiate antibiotics unless you're having bacteremia, you have another source of infection or cholangitis. I think that there is no amount of leukocytosis or left shift or fever that will sort of change or dictate that role for antibiotics. Not that I'm aware of.
And so I think we've sort of been dancing around the topic, but we can kind of go into it more specifically now, is kind of talking about all of the complications. And then you sort of started talking about it just now, but like the timeline for when those complications would happen after the acute pancreatitis.
So if you recall what we discussed a little bit earlier about the Atlanta classification, revised classification, we sort of described two different pathways or two different distinct patterns of pancreatitis: the interstitial edematous pancreatitis and necrotizing. So in the interstitial edematous pancreatitis, you can develop peripancreatic fluid collections as early as 7 to 10 days, and then if the sort of persist, they can evolve what we call them pseudocysts if they persist beyond 30 days or so, or 4 weeks. But you can easily form peripancreatic fluid collections, and as early as 7 days. Sometimes we can see them on imaging. On the other path, necrotizing pathway, you can have either a necrosis of the gland itself or peripancreatic necrosis, which is the surrounding fatty tissue, which could develop necrosis or fat necrosis in that. And usually we also see that on imaging after 5 to 7 days. We can see evidence of necrosis and evolving necrosis, and then over time, over the course of 2 to 3 weeks, it can eventually form a walled off necrosis that sometimes we refer to as WAN or WAPN, which is encapsulated cavity containing necrosis, and that by itself could be sterile or could be infected, and there are a lot of differences between them in regards to the infected ones are often very, very sicker, very unstable, as opposed to sterile are usually just painful with some evidence of sometimes organ compression, like gastric outlet obstruction. They just can't tolerate PO because these collections are pretty big, and eventually they evolve into either a pseudocyst pattern or a wall of pancreatic necrosis pattern in a matter of 3 to 4 weeks.
So that's helpful to break down the complications. And so then when in that process do you have to act on them?
So the only reason to tackle or treat one of these collections, you can break it down to 3 main reasons or 3 main categories of reasons. One, evidence of infection. This is someone, for example, who is day 10 or day 12 in the hospital. They're febrile, they're ill, and now we're worried about if these fluid collections are becoming infected. That's the time that we need to consider doing a CT-guided aspiration in consideration of antibiotics at that juncture. It's often very difficult to perform endoscopic therapy that early on because most often at day 7 to 10, these are not very well-defined collections. The other reason to go after it is if it's causing symptoms, and that's perhaps the main reason that we treat them. Either these collections are fairly large and causing significant pain to the patient, either baseline and postprandial, they can't eat, or it's causing organ obstruction, whether it's compressing the duodenum and it's causing a gastric outlet obstruction, patient can't tolerate PO, or it's compressing the bile duct and causing biliary obstruction. And these are the times that we often have to intervene on and try to drain them. In the case of that there is a concern for infection, we might be forced to do something early on, like a percutaneous drainage. If it's too early within the process and we can't do anything endoscopic because it's not well encapsulated. But for the other reasons, which is usually pain or intolerance, we try, if possible, to drag this to 3 to 4 weeks, and then at that point offer them endoscopic treatment like endoscopic cysgastrostomy or endoscopic necrosectomy to treat it. So those are sort of the 3 main reasons we have to intervene on these collections.
Okay, so continuing the case for Miss Weber. So she had her acute pancreatitis in the hospital, and she stayed as per the recommendation for a cholecystectomy. However, her course was complicated by pancreatic fluid collection noted on imaging later, and then she was discharged home. So what would her post-discharge follow-up look like, and which specialist does she need to see for follow-up, and is there any more imaging required for that follow-up?
So that's a great question. That could, who should you see, that could depend on what, expertise are available at, where that patient is. But I think a follow-up with gastroenterology is very reasonable. We don't often recommend routine imaging unless when we encounter the patient, we are getting concerned about worsening of that focal complication or local complications. In this case, we talked about she might have formed a pseudocyst or a walled-off collection. We do not need to really image her just for the sake of imaging to see it's getting smaller or larger. If patient has no symptom or minimal symptoms, they have no pain, they're tolerating a full meal and diet, that's all they really need. We do often try to check with them again in 6 months or 12 months down the road to assess for evidence of endocrine or exocrine dysfunction, which could have occurred related to pancreas injury. So we often bring them back in 6 to 12 months after to check a prealbumin, check an albumin level, check a hemoglobin A1C. But we won't recommend imaging just for sort of the sake of imaging, unless they are demonstrating symptoms. If they're symptomatic, then obviously we do recommend a cross-sectional imaging to assess, the size and or the effect of this fluid collection, and to see if there's further endoscopic therapy or percutaneous therapy is needed to address that.
Okay. And does that change at all if it's necrotic? I know hers was a little bit more interstitial appearing, but does it change at all if it's necrotic in terms of follow-up?
Not really. No, it shouldn't really matter. I mean, if she got discharged from the hospital and that was not prohibitive of her discharge, there's no difference in that, in how she would, sort of manifest, whether this was develop into pseudocyst or develop into wall-off necrosis. It doesn't matter. Doesn't change our decision making.
Kaveh, I was surprised. Can I brief before we go on? I wanted to ask about the endocrine-exocrine dysfunction, because when I was reading about it, and I don't know if these numbers sounded high, but it was something like 20% of people with mild and 33% of people with severe pancreatitis might develop exocrine pancreatic insufficiency, and that was even after just like their first case, and then about something like 23% might develop endocrine insufficiency. That just seemed really high. For people to have post-pancreatitis diabetes and then also the exocrine dysfunctions. So can you talk about how you recognize those other than checking A1C for the endocrine dysfunction?
So these numbers I think are pretty accurate. I think they're correct. And it's something that, especially in the outpatient setting, we constantly think about. How do we assess beyond labs? I mean, for exocrine dysfunction, maybe a little bit easier to go based on symptomatology. We talk to the patient about their weight. We assess them for steatorrhea if they're having that. If they have any complaint about foul-smelling stools or things like that, that's something to consider if they're losing weight. But we very routinely at 6 month and 12 month post an acute pancreatitis check their prealbumin. We check their fat-soluble vitamins A, E, and D, and try to give it assess about nutritional status if we're seeing subtle signs of exocrine dysfunction. Endocrine might be a little bit more obvious, especially if they are discharged from the hospital with higher than usual blood sugars. That's something that many times it's seen on follow-up AccuChecks or follow-up routine blood tests. And if that happens, they might require diabetes management or lifestyle changes for pre-diabetes, depending on how severe it is. But it is common and sometimes under-recognized.
Yeah, those numbers were scary because we see so much pancreatitis. I guess we need to be more on the lookout for it.
Yeah, I feel like there was an article that said something about like 20% of patients have like a pancreatic duct disconnection or something. I think it was related to that, and that kind of blew my mind too. But No, maybe that was just me.
Probably in the more severe cases. I think in mild cases it's less than that. But so that's these are sort of good tests for follow up, and then maybe an A1C in 6 months just to see how they're looking at.
And just to clarify, it's for severe cases that the percentages are that high, right?
Well, this is from the Lancet seminar article that I had mentioned, and they said that with mild, for exocrine, they said mild, it could be up to 20% of patients could have exocrine insufficiency, and with severe pancreatitis, it could be up to 33% could have exocrine pancreatic insufficiency. So we can put those in the show notes, the references. Yeah, I was surprised. That's why I was asking. It just seemed high. It sounds bad. All right, but I think we have to wrap up here. So we probably are there any last minute questions, Meredith or Monee, other than getting some take home points?
Nope.
No.
Okay, so Kaveh, can you give us a couple? If the audience was going to remember 2 or 3 things about what we discussed tonight, can you remind them what you want them to know about pancreatitis? I wrote down 3 or 4 points which I thought which I see often opportunities for improvement. One is you cannot give too much fluid in acute pancreatitis. I mean, that's probably a little bit exaggerated what I'm saying, but it's just trying to have a good take-home message that early resuscitation within first 24 hours, 12 to 24 hours is really key in these patients and preventing them from getting necrotizing pancreatitis. I think CT scan is really not needed in the first admission, and it could be delayed up 2 to 3 days if there is evidence of organ dysfunction or lack of improvement. And then antibiotics sears by itself or leukocytosis or fever should not mandate antibiotic use or empiric antibiotic use. It is absolutely fine to treat focal issue like cholangitis, pulmonary infection, pneumonias, but empiric is not recommended within the first 7 to 10 days. And I think the last thing will be, things to think about transitioning care of these patients to an outpatient setting. Be on the lookout for long-term endocrine exocrine dysfunction in these patients. Fantastic. We will fade this into the outro.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Anyone's game. Oh, there we go. Get your show notes at thecurbsiders.com, and while you're there, sign up for our mailing list to get our weekly show notes in your inbox. By the way, BT dubs, guys, in the future, if you're waiting for me to say yummy, it will not be happening.
That's why I jumped in.
Each month, you'll get our... Thank you. Heroic work. So anyway, you're signing up to get our weekly show notes in your inbox, plus twice each month, you'll get our new Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we want your feedback, so please subscribe, rate, and review the show on Apple Podcasts or now on Spotify. Give us some stars on Spotify, or contact us at thecurbsiders@gmail.com. A reminder that this and most episodes are available for free CME for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. A special thanks to our writers, producers, artists for this episode, Monee, Amin, and Meredith Trubitt, and to Beth Garbitelli, who is our executive producer and runs our Twitter. Nora Taranto is the editor for the Digest. Maddie Mad Dog Morgan is on Instagram. Tima Karganov does the website. Stuart Brigham composed our theme music. Claire Morgan of Notterly edits our audio. And finally, Chris the Chew Man Chew is on Facebook. Until next time, I've been Dr. Matthew Frank Watto.
And I've been Dr. Meredith Trubitt.
I've been Dr. Monee Got Money, Amin.
And as always, our main Dr. Paul Nelson Williams. Thank you and goodbye.